Welcome to our second and last video on low back pain. Let's begin. In this lecture, we will cover lumbar strain and vertebral compression fracture. We'll conclude the lecture by touching on red flag symptoms that should have you concerned that something more serious may be at play. Let's start with lumbar strain. We'll cover each of these points. Lumbar strain is defined as minor tissue tearing within the low back. This results when an unbalanced muscle contraction occurs. This may occur in a patient who is lifting or twisting. This image depicts what happens when a patient experiences a lumbar strain. In this instance, a small tear in the inferior portion of the trapezius muscle is shown. This tearing of the muscle leads to inflammation and pain. Trauma and strenuous exercise are two of the biggest risk factors for lumbar strain. Common examples of strenuous exercise in question stems include lifting heavy boxes or working out for the first time in a while. Patients that are obese, have spinal deformity, or exhibit muscle weakness are also predisposed to this tearing of the back muscles. These patients will have a dull pain in the paraspinal region of the lower back, which is sometimes referred to as a paravertebral tenderness. They will also be without neurologic deficits since the muscle has been affected and not the nerve. As mentioned, paravertebral tenderness is an important clinical finding in making this diagnosis. To help distinguish this from a herniated disc, note that patients will have a negative straight leg raise test. There is no imaging required for making this diagnosis since it would not alter the management course. This is a diagnosis within this lecture that should cause the least concern as it tends to be self-resolving. The theme of NSAIDs as part of treatment for low back pain continues here. We also want patients to continue to be active. If pain continues without any relief, and the patient is especially bothered, a short course of non-benzodiazepine muscle relaxants such as cyclobenzaprine may be given. What side effects should a patient being prescribed cyclobenzaprine for a lumbar strain be warned about? Cyclobenzaprine is a non-benzodiazepine muscle relaxant. It works by blocking nerve impulses. Because this blockade is nonspecific, it can block impulses to the brain, causing drowsiness. It can also give anticholinergic effects such as dry mouth and constipation. Let's finish our list of diagnoses with vertebral compression fracture before discussing red flag symptoms. Here's our overview slide again. Put very simply, a vertebral compression fracture is a break in the vertebrae. This occurs as the bone begins to collapse on itself and loses its height. It's most helpful to see this depicted visually. Here we see an illustration of a vertebral compression fracture. Notice the way the bone seems to crumble on itself. The risk factors for vertebral compression fracture are anything that weakens the bones. With age, the bones lose their strength, so age greater than 50 years old is a risk factor. Other reasons for bone to become weak include osteoporosis, steroid use, bone metastasis, and Paget disease of bone. The key clinical finding for these patients is point tenderness over the spine. There will also be limited movement of the back, and symptoms get worse with standing or walking. This makes sense given that the bone that provides support to the spine is fractured. Bony pathologies often rely on X-ray for confirmation of the diagnosis, and this is no exception. Also note that a vertebral compression fracture is not normal, even in an elderly individual. Thus, a workup for osteoporosis should also be undergone in these patients. This is an X-ray showing a compression fracture of the L3 vertebrae. Notice the way the bone seems to have almost fallen on itself. So what tests should be ordered in the evaluation for osteoporosis in a patient with a vertebral compression fracture? The list of possible tests is a long one, so we'll focus on some of the most critical ones. We should order a CBC, since the blood cells and bones are intimately connected. A biochemistry profile is important to obtain, and we should pay particular attention to the calcium, phosphorus, and alkaline phosphatase levels. These levels can tell us something about the bone's health and possible secondary disease processes. Ordering a 25-hydroxy vitamin D level can help us to tell if vitamin D deficiency is at play as a secondary cause of osteoporosis. Finally, we can perform a DEXA scan, which paints a picture of the patient's overall bone mineral density. The primary treatment for vertebral compression fracture is centered on conservative management. This includes oral analgesics such as NSAIDs and modified activities to give the fracture time to heal. The vast majority of patients will get better with these conservative measures within 6 to 8 weeks. In rare cases, more aggressive pain control medications and even surgery may be recommended. As was the case in most low back pain patients, bed rest is not advised and may be disadvantageous because of the negative effect it can have on bone mineral density and muscle strength. We'll wrap up this lecture by briefly discussing a few high-yield, can't-miss red flag symptoms in a patient with low back pain. This slide provides a quick review of some red flag symptoms in patients with low back pain. If the patient has saddle anesthesia, lower extremity weakness, decreased reflexes, and urinary retention, you should be thinking about cauda equina syndrome. This diagnosis is covered in greater detail in our lecture on spinal cord diseases. In a patient with fever, worsening back pain that is tender to palpation, and lower extremity weakness, you should be thinking about a spinal epidural abscess. This is reviewed in our lecture on brain abscess and spinal epidural abscess. Finally, a patient with weight loss, night sweats, a dull ache that is worse at night, and lack of relief with NSAIDs should have you worried about metastatic cancer. How can the X-ray findings of the spine in a patient with multiple myeloma be distinguished from those with metastatic prostate cancer? Multiple myeloma is a white blood cell cancer that is often remembered with the mnemonic CRAB. C for hypercalcemia, R for renal failure, A for anemia, and B for back pain or bone lytic lesions. This means that part of the bone is lysed and a darkened area is seen on X-ray. In a patient with metastatic prostate cancer, the bony lesions are described as osteoblastic. This means that the bone is built up and whitened areas of hyperdense sclerosis are seen. Let's look up some radiographic images to solidify this point before we finish this section. Here we see an X-ray image of the arm in a patient with multiple myeloma. Each of the darkened regions scattered throughout these bones is characteristic osteolytic lesion of this disease that may be also present in the spine. Here is an image of a patient with metastatic prostate cancer. Notice the osteoblastic lesions indicated by the arrows where whitened areas of sclerosis can be appreciated. Here's a table that reviews the causes of low back pain discussed in this lecture. A 70-year-old woman comes to the emergency department due to severe low back pain that started 2 hours ago. She has past medical history of systemic lupus erythematous treated with oral corticosteroids. Her vital signs include a temperature of 37 degrees Celsius, a blood pressure of 145/85, a heart rate of 81, and respiratory rate of 16. The physical exam reveals point tenderness at the low back. The spinal X-ray shows saddle back deformity and decreased height of the L5 vertebral body. Which of the following is the best initial step in the management of this patient? A. Diclofenac, B. Hydromorphone, C. Surgery, or D. Bed rest. This patient presents with acute low back pain and point tenderness of the spine. Considering her age, gender, and chronic use of corticosteroids, this patient likely has an underlying osteoporosis. The spinal X-ray shows saddle back deformity and decreased height of the L5 vertebral body. This description is classic for vertebral compression fracture. The best initial step in the management of vertebral compression fracture is the oral analgesics like nonsteroidal anti-inflammatory drugs. Diclofenac is an NSAID. Therefore, the correct answer is A. Here is the slide reminding us of the management of vertebral compression fracture. So let's discuss why the other options are incorrect. Option B, hydromorphone, is incorrect because it is a strong opioid analgesic predisposing the patient to respiratory depression and falls. Vertebral compression fracture should initially be treated with oral analgesics like NSAIDs. Option C, surgery, is incorrect because it's usually performed in severe or refractory cases of vertebral compression fracture. Finally, option D, bed rest, is incorrect because it's not recommended for vertebral compression fracture. And that concludes our lecture on lumbar strain and vertebral compression fracture.